think we should get started. Okay. First, I don't know what Jason is. I really want to thank Jason for having me here. Very excited to be back in Taiwan. And also for the TAROS committee. This is a topic very dear to my heart. I really think we need to rethink how we think of radiation oncology. Otherwise, I think we're going to be wiped out by our medical oncology colleagues with immunotherapy. I really believe this. We are very good here for our development in radiation oncology. We have a lot of toys, but we are not exploiting the biology enough. This is the area that I want us to really think about. These are my disclosures just on advisory boards. So I want to tell two stories. The first one is on HPV-driven oropharyngeal cancer. It is the most common cancer in the United States and is probably increasing worldwide. Some of us are not head and neck radiation oncologists or oncologists, so I'm going to just tell you some standard of care. So the current standard of care for HPV-driven cancer is the 7 weeks of chemoradiation. This has not changed for the last 40 years, right? Surgery, probably now we have robotic surgery, followed by post-op radiation therapy, and chemotherapy is another septic standard. But when you look at this, there's very high toxicity and late complications. And as a result, there are many efforts by the surgeons, the medical oncologists, the radiation oncologists to decrease and to de-escalate. And if you go to any head and neck meeting or any meeting, it could be rehab, could be dental, there's going to be a session on reducing toxicity. So that's the standard of care. And I'm going to now go through a series of non-selected de-escalation approaches, which have failed today, unfortunately. Okay, first, foremost, a story of cetuximab. We know that cetuximab was FDA approved in 2006, but unfortunately, compared to cisplatin, with decades of research saying how good cetuximab was, but when you compare to plain old cisplatin, it was inferior. So no one talks about cetuximab anymore. I think maybe even 5, 6 years ago, 7 years ago, you go to sessions, they're going to talk about cetuximab. But that story is ended, even for very low-risk HPV-positive oropharyngeal cancer. So that story. The story is very interesting. Look at medicine, right? It goes in cycles. So cetuximab doesn't work. How about immunotherapy? PD-1. That's something that everyone's so excited about. But I knew for a long time it's not going to work, but people still wanted to do the trial. And Su Young did this head and neck 005 trial, escalated RT with cisplatin, escalated RT with single agent nivolumab. Complete disappointment, more failure with nivolumab compared to cisplatin arm, and the progression-free survival was inferior. You could look at this. Another disappointment. So we went from cetuximab doesn't work, let's try PD-1, PD-1 doesn't work. There's a lot of reasons why, but I really want to call this attention. This is a paper that I written with Javelin. This was anti-PD-1 with chemoradiation. But what happened was in this study, I got a lot of tissue. So with Nadine Rias and Tim Chan, we studied this. This paper is under revision, but I can tell you this. When it's a negative study, nobody wants the paper. I mean, it almost made it to Nature, but kept going down, and I mean because there was a retraction. I could tell you the story. It has to do with the tumor bacterial burden, TBB. And this paper should come out this year. It's under revision in another really high impact journal, but very hard. And I can tell you one thing, it is not the field design. People think, oh, PD-1 doesn't work in head and neck because we have big radiation field. It's not that. Because if you look at the study, people with PD-1 high tumor, they did work, right? And then maybe it's just 7 weeks. It's got to be SBRT, but look how many SBRT negative studies we have now with PD-1. So there's a reason, and this is a really good paper to read. Why is it that you cannot give PD-1 concurrent with radiation? Okay. Now, we just talked about cetuximab doesn't work, nivolumab doesn't work, but HPV-positive tumors are very radiosensitive. How about we just get rid of cisplatin? Why do we need even cisplatin? Maybe radiation alone is enough since these tumors are very sensitive. Su Yang did the study, again in energy oncology, more failure with the RT alone arm. Worse progression-free survival. So you need platinum, you need radiation. Then energy oncology say, okay, we need platinum, we need radiation. Why don't we just drop 10 gray? Everybody drop 10 gray. Instead of 70 gray, go to 60 gray. Again, a randomized study here, 70 gray versus 60 gray, cisplatin, cisplatin. It was shocking. This is shocking to all of us, right? You can't even drop 10 gray of radiation. Inferior outcome compared to 70. Progression-free survival. So that's it. We're back to after 40 years of head and neck research. 70 gray, 3 cycles of platinum, or 70 gray, weekly cis, whatever it is, but you need both chemo and radiation. But how about using technology to de-escalate? And I do want to call your attention to this study. This is another shocking. This paper should be published this year, Steve Frank's phase 3 randomized study comparing IMRT to proton. What's shocking to me is the survival advantage. Look at it. At year 3, the curves start to separate. IMPT significantly better than IMRT. That's pretty shocking. Why is that? We don't understand. There's some heterogeneity in this study, but we're going to meet some resistance because the medical oncologists, none of the studies have this kind of survival advantage. What is it about proton? We don't know the answer, but this paper nonetheless will show you that at least it's not inferior. That's one way to de-escalate, right? So we can use technology. But proton, like I said in the prior session, it has its own issue. But now, outside of clinical trial, what can we do? This is very dear to my heart. I do not understand why people have issue with this. So at MSKCC, this has become our standard. We do first phase, 30 gray, 2 gray per fraction. This is our target. This is a typical base of tongue tumor. Then we just treat the gross tumor, GTV, another 40 gray to 70 gray. So 30 gray plus 40 gray equals 70 gray. We published this paper. Jillian is the first author. And then basically, I can tell you, if you look at all microscopic dose, there's no randomized study on this. You can look at it across the board throughout retrospective study. It's anywhere between 30 gray at MSK versus 63 gray at some centers. So what's happening is that this explains the toxicity. Here are the constrictor muscles. If you give 63 gray there, it's going to wipe out your constrictor muscle. You're going to have swallowing difficulty. So a lot of people push us to do randomized study, but my question is, why is there even randomized study to do 63 gray? There is none, but people accept it. This is our 2-year local control, progression-free overall survival. We didn't compromise care. We updated, one of my proton fellow, Amir Safavi, updated it with 64 months follow-up. It's holding up. We don't have a single patient that failed in the subclinical region. We treated subsequently 400 more patients. The good thing is, I am so happy that Su Yang, and Jilly is going to be the PI, is doing this energy oncology randomized study based on the Memorial data. Going to do exactly what Memorial does. This is experimental arm, and then 50 gray is the accepted standard. So we will have this, but by the time this is published, what, another 6, 7, 8 years? So something to think about, okay? And then, of course, there's other parts about cell-free DNA that we might use. So I wanted to tell you that story. Now, to summarize what I just said, to put everybody on the same page, OPC de-escalation studies so far still treat the gross tumor very high doses. Even our subclinical dose reduction papers, the GTV still get a lot of dose, which is 70 gray. That has not changed for the last 40 years. There's a lot of efforts on non-de-escalated, selected de-escalation. I showed you all those papers that failed. More importantly, we don't really know why. And that's the problem, because we didn't get tissue and we don't know why. And it poses a problem. So it's almost like you kind of just blanketly de-escalate. So the question I had about, whoa, this is, oh. Let's see if this is working. The question I had is about 10 years ago, or actually about 15 years ago now, it's like, why do we need to treat everyone the same? We are in 2025 now. Why does one size fit all? We know it doesn't. We know that medical oncologists talking about precision medicine all the time. Why not precision radiation? That's the question I asked, right? I'm going to talk about two major approaches that MSKCC has done for this disease. First one, I want to talk about the surgical approach. Remember, we have robotic surgery. I think that's in Taiwan as well. The hypothesis we had is, can we use ctDNA to detect the MRD, minimal residual disease state, after surgery to guide adjuvant therapy? Similarly, what we do for prostate cancer, right? We don't give post-op RT unless your PSA is rising. So we really thought ctDNA might be a good biomarker. So we did this study by Linda Chen, my colleague. We had to use NavDx Naveris because that's the only clear certified test. You can't do it in a research lab or if you're going to run a clinical trial. You have to have a measure of positivity. You take your surgery, take an all-growth disease. You had to have an indication for radiation. And then we had 2 time points, post-op, ctDNA, and MRI that show there's no disease. And then we had this algorithm. If it's negative, observe, like prostate. If it's positive, no growth disease, just delay radiation, like delay prostate radiation. But if you had a growth disease, despite negative ctDNA, you're taken off study. And it was a plenary session, and it was shocking. 25% of patients failed. Despite, remember, I had 2 time points negative ctDNA. And guess what? On my way here, 2 more additional patients failed. So liquid biopsy is not good enough to de-escalate right now. It's not sensitive enough. Here's an example of a patient, 1608, post-op negative, 3 months negative, 6 months still negative, but gross recurrence on PET. So right now, the field of liquid biopsy, you cannot use it as a biomarker to de-escalate. A lot of people use it to escalate. There may be some talk, I think, in GI cancer to de-escalate in terms of adjuvant chemo, but in terms of radiation, very dicey. You cannot do it, okay? And then we have that ongoing. Then we wrote this editorial. The question really is, sensitivity test is too low. It's not good to use to omit therapy. And maybe you can use it when imaging is equivocal, but there are new era assays. I still think liquid biopsy is the future, but it's going to take time to get there to improve the sensitivity. Okay, so that's the surgical story. So we couldn't use ctDNA to de-escalate. Now, onto my passion, which is, can we personalize and de-escalate, achieve the same outcome using a non-surgical approach? So this is our 30 Rock trial. 30 Rock is an American satirical sitcom, sorry. And then here's the HPV radiosensitivity for the resident. This is actually a really good paper. It talks about different buckets of why HPV tumors are sensitive. So here's hypoxia, is what I'm going to focus on. I think everybody knows hypoxia is bad. Low oxygen. Preclinical, clinical, animal study across all cancer types, it's bad. No one's going to question this. It's even bad for HPV positive tumor. More and more data shows that. And then it portends more radio resistance. So there was a lot of work about escalating therapy, but then I took a different turn to say, can we use it as a biomarker to de-escalate? So then keep that thought in mind. There's one way to measure hypoxia is using HIF-1 alpha, but that's invasive immunohistochemistry, and I want to call you to this panel. If you're HPV positive and you're hypoxic negative, meaning HIF-1 alpha negative, you did well. But if you're HPV positive, but you're hypoxic positive, then you didn't do as well. So you're not going to want to de-escalate this group, right? You want this group. So we have another update too. One of my Chen is actually going to Hopkins to do head and neck, one of our residents. I'm very excited. We show that hypoxic tumor just do worse. More distant metastases, and then worse overall survival, And especially you have persistent hypoxia, imaging shows, intra-treatment, they're gonna do bad. So if you're gonna de-escalate, these are the people you absolutely don't wanna de-escalate, right? So now this hypothesis continuation, it makes sense. Don't de-escalate hypoxic tumors. Again, low oxygen. Now, how do you do it in the clinic, right? We talk about precision medicine a lot, but you gotta think what is practical in the clinic. You're not gonna stick a probe in someone's neck. That's very invasive. You can image hypoxia non-invasively is the most ideal. You can use PET and then different tracer. Look at FASA, IAZGP, copper, EFI, F-misol, and pros and cons of each. We did all of them. A lot of people like FASA. It's not great. I pick F-misol because that's the most robust. We had a lot of data on that. Yeah, there's some image issue, but I'm going to show you image quality. It's pretty good if you perfect it. Now, the question is how much you de-escalate. Now, Dan, in anal cancer, right? We're going to talk about anal cancer. So here, we got to be safe, right? When I want to de-escalate from 70 grade, must be safe, must be meaningful. We did some 10 grade reduction. It was still very toxic. So this is the guy that came to my mind, Dan. When I was sitting in my office one day, about over a decade ago, it's like aha moment. Dr. Nigro treated HPV oropharyngeal cancer only to 30 grade with mitomycin C and 5-FU, 95% cure rate. So I asked myself, why do you need 70 grade? So it's a big jump, right? 70 grade, jump down, lower down to 30 grade. We kept chemotherapy because I'll explain later, it affects the DNA repair pathway. I think platinum is needed for this disease. So protocol concept came about. I got my biomarker because it's going to help me find out who doesn't have hypoxia, right? Negative scan, non-hypoxic tumor, radiosensitive tumor. These are people I'm going to de-escalate. I know what dose I want to get to, 30 gray, right? Because I'm going to drop from 70 to 30. It's a big drop, 67% drop. And then, but I need to have buy-in. You can design the best protocol resident, but no one's going to give you patients. So you have to work with the surgeons, all right? Because robotic surgery is in place, so you have to work with them. Then you need funding. Nobody cares about radiation study, honestly. No pharmaceutical cares about it. I don't have money from, I ran that Javelin study. It was $8 million in my bank, easy. But this is a radiation study. No funding, NIH, and patient donation. That's the only way I can do it. So I'm going to tell you a story. So we did this study, 19 patients as a proof of concept. This is the key. So here, you got the tumor in primary, and you got the tumor in the neck. We actually allow them to do robotic surgery. This turned out to be a blessing. At the NIH, they will not let me de-escalate the primary site. So I had to go to 70 in the first iteration. We had no choice, right? So then but then they allowed it if you take out the tumor. So the surgeon came in, left the neck node behind, took out the tumor. But it turned out to be my blessing because we had so much tissue to study why a patient failed or not. We did a lot of sequencing. And then we kept the lymph node, no evidence of hypoxia, 30 gray, and 2 cycles of platinum. End of RT. Watch this. Lymph node's still there, but you have to believe your hypothesis. You trust it. You follow. We follow very closely. This was 2015. To a tiny little lymph node, and I had a mandatory neck dissection. Because I knew if we're going to publish this, people are going to want to path data. So we mandated. Even though the FDG PET was negative, we still asked the surgeon, go to the OR, take out whatever you see. We did all smokers. We did a lot of correlatives, which I'll go through. We even did financial toxicity. 3 of my surgeons bought in. You need people to want to buy in. The other surgeons thought I was crazy. But because, why do you want me to cut out half the tumor? But you still have your colleagues to support you. So we did this. Look at this past CR. Imagine this is immunotherapy PD-1. It's going to be like front page on New York Times, right? It'll be New England Journal of Medicine. Because it's radiation, nobody cares about it. But we managed to get into JNCI. I spoke to the editor. I was like, please get this in. This is an important paper. So we got this. Everybody had a response. Most people had a complete pathologic response, despite only 30 gray to the growth node plus 2 cycles of chemo. And then we very excited, right? And here, research. I'll quickly tell you, volume. People say, well, Nancy, F-MISO, too complicated. I can't do it. Dan even said that to me yesterday, right? But I'm going to prove Dan wrong. So here, you see the GTV. If you see week 3, the lymph node's still there. You can't de-escalate. I want to make a decision. Volume was not good. ctDNA, maybe ctDNA is good, but it's all over the place. And then if you look at Bishan-Chera's data from UNC, you need to wait till 4 weeks for clearance. But I want to de-escalate at week 3. This is too late, right? So ctDNA isn't good. Then this is our more work. We perfected the assay. We said, let's do a personalized panel HPV. So we improved the assay detection, but still wasn't that good because among the people that de-escalated to 30 grade, 64% still had persistent ctDNA. So that means I would have not be able to de-escalate if I use this biomarker. So that wasn't very good. See, this is our 30 grade, still had positive ctDNA. So that wasn't good. So F-MISO still better. Then we did ADC. I mean, believe me, we did ADC, kurtosis, every single DWI, DCE, every interrogated, nothing worked. Okay? So that was that story for MRI. How about DNA repair? I need to talk something about DNA repair because even though F-MISO allowed us de-escalation, we need to know the genetic basis of why there's a responder and why there's no responder. And if you think about it, right, think about biology. E7 targets RBE, affects the non-homologous end joining, which is one of the major DNA repair pathway due to radiation. So you put RT here, you kill this repair pathway. HR is what repairs cisplatin. So you get RT, cisplatin, you knock out 2 major repair pathway. This spikes up alternative end joining, which is error-prone. You can measure this. So people that have the defect, you should be able to measure. And we did this, but not great. Look at this. This is another problem. Everyone wants genetic basis, but sometimes tissue is not perfect. Look at it's not the bar. It's not like this, high and then responder down here, non-responder down here. So there are still issues. You have to do whole genome sequencing, ongoing work we're doing. But suffice to say, it's not perfect. And then here's immune. I gotta say something about the immune response, right? Immune response right here. This is pretty cool, but very hard to do. I don't know if we could do it. Every T cell has a barcode. We're gonna match the T cell with the antigen in the virus, HPV, and to see if that T cell is killing that antigen, right, in the tumor. So this is ongoing work, very hard to do, but we collected a lot of blood samples. So those are some research. Now back to the clinic. First, this is the updated paper that we had. So 1 variable at a time we took out. We only took out the need to do the planned neck dissection. This paper still allowed the gross disease to take out. Because remember, residents, you change 1 variable at a time. You change too much when your study is negative, you don't know why. But we had started with 158 patients, de-escalated 128 patients, about 80% de-escalated, only had 30 gray. Example, here's FDG PET, F-MISO completely cold, NED, 30 gray, right? Then you have FDG PET, here's F-MISO positive. Dan, I want to show you this. See, you can see it. It's really good. And then negative. It's actually, I can read these scans. It's not that bad. And then you have FDG PET, positive, intra-treatment still positive. It's a little faint. We can perfect this. But this patient tells us this person's 2 weeks into treatment still persistently positive hypoxia. They're not going to be good players to de-escalate. So we went to 70 gray on them. So that's how we differentiate intra-treatment. That's what you do as a radiation oncologist, guys. We have fractionated radiation. You need to look at what happened to the response of your treatment during treatment to dictate whether you go up or down in terms of your radiation dose. Okay, so really good progression for local regional failure, 5%. We had no primary side failure. 8 patients needed salvage neck. 27% had positive margin of ink. 2-year local control was 95%. So we did not compromise despite giving 80% patient only 30 gray, right? That's pretty low. We de-escalated smokers. In general, smokers were more likely to be hypoxic, but if you are a smoker and you didn't have hypoxia, you had equal chance of control as if you're a non-smoker. Smoker is not a very good indicator of biology of the disease. And then 2-year progression-free survival of 94%. One patient failed both local, regional, distant. 2-year overall survival 99%. One patient died of PE in a 70-grade arm. So with that, of course, everyone, at this time, I'm getting very nervous, right? Everyone's like, all right, only Memorial can do it. And I wanted to prove the world wrong, so I want to bring this to the world. So I said, all right, now we're going to open cohort B, another 158 patients. And then we no longer have surgery at all, just straight patients. And then I want to replicate it in Miami and Hartford, Connecticut. We generated the tracer. We flew down on an airplane from New York all the way down to Miami. They scanned 5 patients, Hartford 5 patients. We drove to Hartford. So I want to show that it works outside of Memorial Sloan-Kettering Cancer Center. And then in this study, about a quarter were greater than 10-pack-year smoking history, and about almost half the patients were T2 tumors. Remember, we did not do surgery to the primary anymore. And about 16 patients were N2C disease, bilateral neck. And then most patients had cisplatin. We had some patients started wanting proton, so we allowed some proton. Look at this local failure. It's beautiful. It was the same as if you're 70 gray or 30 gray. Regional failure. Regional failure is the same, 4.4%. And then we also wanted to know, what if you cannot be salvaged? Maybe we didn't take out the primary, you can't salvage. But it turned out we only had 2 patients that cannot undergo salvage. One was a 30-grade, developed a second neck recurrence. The other one was actually a 70-grade patient. Both people are alive and getting treatment. This one's still on maintenance IO. This one is on maintenance IO as well. So the 2-year local regional control with successful salvage was near 99%. So we know we're not harming the patient. And look at the 2-year progression-free survival of 91%, 2-year overall survival 99%. Remember, these are 30-grade patients, right? About 74% has 30-grade. Look at the night and day. You guys can guess which one's 30, which one's 70. And then look at the toxicity, grade 2. This is for 30 grade. You're still people start complaining about taste. It's crazy. Patients have they always find something to complain about. Taste. Someone even lost 30 pounds because things didn't taste right. I was so mad at him. He ruined my data, right? And here's grade 2, look at it. Look at the about 3-fold increase, or at least more than, it's just more than the 30 grade, right? And then grade 3, hardly any, there's still some a little bit, maybe a little person had a little bit dysphagia, but in general, not bad. And then here is the late toxicity dysphagia, 1.8 for grade 1 versus 10. But in general, they did pretty well, okay? And grade 2, and then 2.7. And then I don't know why it's going so fast. But here, we also did an objective study. We looked at it, objective swallowing. So it's not just patients say I can swallow or not. Objectively, what's happening? Look at it. No one has data like this. Like hardly anyone have any problem with swallowing, objective barium swallow. So we know lower dose really helped our patient. And then we have the MDADI score, right? And then you can see they all come back to normal. Everyone comes back to normal. But at some point, the 30 grade just do better. They come back to functionally much faster. And we did a lot of score, but this is an example to show you. We also did financial toxicity. Look at it. If you are a 30 grade patient, you went back to baseline. But if you're a 70 grade patient, you never went back to baseline. These bars means that they're spending more money doing their health issue. Financial toxicity is a big issue in the United States right now. Okay, never return baseline. And then we had an editorial. I was so happy. Like people started, even the NENJM Journal Watch. I just found this, so I wanted to show that people are really into this whole hypoxia concept now. Now to the FDA. Dan, this is for you. I was like, no, we're not going to give up. So I spoke to the FDA. We have this ongoing phase 3 study. Very exciting. I spoke to the FDA 3 times. Did you know that F-MISO, even though you can use it in human, you have to do it under an IND, right? So then in order to give it an IND, you have to do a phase 3 study. So it's a double-blind study, 2-to-1 randomization, 291 patients of this personalized based on intra-treatment hypoxia, 30 gray or 70 gray, versus standard care. Everyone gets 70 gray. It's double-blind. I'm going to explain to you how can you double-blind radiation. We have enrolled 30 patients already. 291 were open to multi-center. FDA was they actually thanked me toward the end because this tracer's been around, but nobody can do it unless someone does a study. So here, double-blinded. Patient and I were blinded. We have no idea. Patient doesn't know, I don't know. The nuclear medicine doctor is also blinded. He doesn't know, he just sees a patient number. He's reading the scan independently. The only time you can unblind, because you can't give sham radiation, right? You can't do sham radiation. So the only time is a phone call from a patient, research assistant, your patient can stop at 30 gray. Then you know by inference the person was on the experimental arm and had non-hypoxia. That's the only time. But if you're 70 gray, you don't know if your hypoxia persistent or your standard of care arm. And by doing this, you keep the patient on trial. Because if you told the patient you're non-hypoxic, they're going to quit radiation, right, based on 500 patient data. So this is one way you can do the randomized study. So we're pretty excited about that. And then we have reproducible readings. If positive, this will lead to a FDA indication similar to PSMA PET. This will be my contribution to mankind, including Taiwan, because I know you guys have a MISO. And once it's done, this is our primary objective. It turned out to work in our favor because FDA loves survival. They don't like progression-free survival. Survival, this should be a positive study because we can salvage these patients. However, it's dicey. If you die of any cause, it's counted as event. So we're very careful who we enroll. Okay, so that's what we're excited about. And then it's easy. I want to show you this to Dan. I just had to show it Dan since he's here for everyone. This is, you buy this from General Electric. You can buy this as F-MISO or FDG. We do that. Your FDG is bought from GE right now. You need a cyclotron. You definitely need it. Major medical center is going to have a cyclotron. And out comes your tracer. It's like your Blue Apron. You know, you have your kitchen knobs, right? This is your kitchen knob. Blue Apron delivered to you, frozen food. You cook it here, out comes F-MISO. That's what you're doing for FDG right now. You're doing the same exact thing now with F-MISO, okay? So that was that. Now, other iterations of 30 gray, we got really bold. I went nuts on this. I started saying, why do I need to treat subclinical? That's what we treated. And then my surgeon halfway got really mad at me and said, no, you have to treat subclinical. So after 50 patients, we had to stop the trial. But it allowed me, this will be a really stringent, if you're going to go to Astro, go to this. This probably will be an oral presentation. We find out a lot of things. I can't spill the beans, but we compare back people that had the whole neck radiated versus not. What happened to their peripheral T cells? You guys will see, okay? And then we have other iteration. We did cisting eligible patient. How about the T3, T4, N3 patient? Give them some induction chemotherapy and then the pathway. And then we have a larger trial actually officially open. This is what Trump, our dear President Trump, held my NIH funding in NIH. So right now, I can't run a trial until he released the money, right? Thank God I don't have DEI in my trial, but I don't know. I'm getting really worried. But here, that's where we are. And then we have this T1, T2 also. Okay, but if you think about 30 gray, it is very binary. It's either 30 or 70. So how do you do precision radiation? See, you start either 30 or you have to go to 70. How about in between? These studies are not that easy to do because you have to run the trial to do this. You can't just say, oh, I'm going to give this guy 40. I'll give this guy 50. You need patience, right? So we are doing this, and I think this is the future, guys. We will get to a point one day and you got to use AI. I'm sorry to say, no more human being. This is not going to work. We went through it with our MRI, DWI, 1,000 images, a lot of man hours. You need AI. You need AI. That's what we're doing right now. I think this is very exciting, our future. I can imagine AI coming in, help us to determine. So I wrote this grant. This is a grant that was supposed to be funded, but it's stuck. If you're 30 gray, right, you're stopping at hypoxia negative, you're stopping at 30. But among the 30% patient we estimate that are going to 70, maybe I can use machine learning, have some probability, and have an intermediate dose. So I'm going to divide HPV to low risk, high risk, which is 70, or an intermediate risk. And these are people that are given the middle dose, right? Why 46 gray? Well, I think about EBV, nasopharyngeal cancer, 40 gray, another viral. So I kind of dropped the dose, 46 gray. It's pulled out a half, but with some understanding. I didn't want to do 50 because that's too boring. So we went down to 46. But hopefully we will find this and be the next trial. Then we just talk about cisplatin being very needed, but can we replace cisplatin? This is an old drug. It's been around since the 70s, but every trial failed. But how about HPV positive tumor that are PI3 kinase positive, 40%, right? What if you use an alpha inhibitor? We did this other trial. We went to 70 gray, but BYL is an alpha inhibitor of PI3 kinase. And look at it, after 8 days, tumor already gone. But look at this, after 3 weeks, the tumor is already gone. That's why 30 gray is probably the right dose. So can we imagine this is the future? I love this. You come in, you profile the patient using AI, something about features, whatever it is. Well, maybe does AI scan you, right? We don't know. Then you say, oh, this person should get PI3 kinase inhibitor. Oh, this person can only get platinum. Sort of like lung cancer. Lung cancer is way ahead of us, right? So we don't have that many targets, but we have some targets. And then that's just the drug portion. But how about use some kind of intra-treatment PET response, namely F-misel here, and drop your radiation dose, low dose or high dose. I think that's how we treat tumor in the next decade, maybe next 2 decades. It may have to happen after I retire, because remember, these studies take a long time to do, but baby step. I hope to solve this for people, and then we have to work on this. Then I'm going to end by talking about another story, which is very, very dear to me. Now, looking at another way to de-escalate, this is not in head and neck cancer. Now it's all cancer. Genetic markers for personalization. Everyone knows ATM is important, right? ATM tumors, mutation, if you knock it out, the repair, right? ATM, ATR, the major DNA PK, the major repair protein. If you knock it out, you can't repair your DNA that's defected. And Jeremy Sutton, we published this paper looking at if you have a loss of function of ATM, you had less progression compared to just normal variants. We did our impact testing, we looked at this. And then if you have biallelic, 2 of the DNA allele loss of function, look at this. Look at your control rate or your lack of progression of tumor versus if you are a variance of unknown significance. So you know there's a genetic basis. ATM tumors, they do better with radiation. If that's the case, why do you need a lot of dose of radiation? You should treat patients differently. ATM mutation is not that common, more common in lung cancer, prostate cancer, pancreatic cancer, 10%, right? So I want to show you this. This is a head and neck cancer. He's 93, came to us, like, what do you do? 3-cycle quasha, melted the tumor, unheard of, right? He's doing well. So turned out he had an ATM mutation. This is a angiosarcoma. We know these tumors don't do well. Chris Barker did there's another trial, 4 grade times 2. You can't go lower than that, right? RT alone, complete response. Okay, ATM mutation. But you know, tumors are very smart, right? We want a genotypic direct personalized radiosensitive ATR inhibitor. I'll explain to you what I mean. ATM, right? We knock it down. sensitive. But tumor is very smart. Tumor is going to want to grow. Tumor is going to find a backup pathway using ATR to repair. But we can target ATR with drug, right? Tumor can no longer repair cell because you created such craziness in the DNA that it doesn't know how to repair cell if it dies. And non-selected, these are typical cell survival curve. You have FOT, RTR low, you add the inhibitor, better in terms of less tumor growth. However, if you select the ATM mutant, look at this. All these mice, they are alive without tumor, okay? So that was a preclinical idea, and we brought it to the clinic. 5 days of this drug, ATR, given 1 hour before the radiation. You have to time it because you want to cause double whammy, ATM mutation, ATR at the same time, right? And then, Dan, this is a pancreatic liver met. That is the tumor, huge. 4 gray times 5, that's all it is with ATR. Look at that. 6 months, look at that. Low dose. You guys and I know these big fat liver tumors do not respond to low dose radiation. So we were so excited about this. We did 50-something patients. Another thing I learned as I kept going, I was like, this is it. I mean, we talked to the New England Journal editor. He was very interested. But guess what? The company went bankrupt. So I can't finish the trial now. That was crazy. So now I have to close the trial early. So I don't know if I'm ever going to get this. I mean, this is just crazy. This is a real story. But about a month ago, I went into like a massive depression because they don't have any more money. So I had to finish trial early. We'll see what happens. But anyway, look at this response. My point is there are tumors that don't need high doses, okay? This is what we need to do, genetically select the right patient and give the right dose and right drug. Okay, in the conclusion, oh good, that's great. I really want to say again, I told you a couple stories, right? About targeting the DNA, right? The one I just talked about, and the FMIs are looking at intra-tumor response. So I think we really need to exploit this. We spend too much money here. Like, Memorial has everything. We got proton, we got mRNA, we got ethos, we got hypersite, we got everything you can name. A lot of toys. But my question to the field of radiation oncology, we have so many toys, but why don't we have any changes into radiation? Everything's the same. You look at breast cancer, they didn't really change their dose. They just went hypofractionation. I think we need to really change the dose. Like with medical oncologists, they have a target, they have a drug. Radiation, you can only go north or south. That's it, right? You don't go sideways. So you find something that you can trust, and then you change your dose. That's what I think we should do. I really hope to transform the practice of radiation therapy from this absolutely empiric blunt tool, just zap everybody, to this biology and information-driven targeted approach. That is where we need to go to. If we don't go there, guys, I hate to say this, we will be wiped out by our medical oncology colleague. If we're going to depend on them, they're already wiping us out. They took away lung cancer, they took away breast cancer, they're coming to head, neck, GI, a lot of the cancers. So radiation's coming smaller, I mean, more oligomet trial. That's why we need to have more trials like Jillian. We got to find indications. Otherwise, we will lose as a field unless we go toward this route. If we don't go toward this route, it'll be the same old thing that we do in the next 5 decades, and kind of boring. Anyway, thank you for your attention. None of this work can't happen without our whole team. I can't do this alone, but thank you for your attention. 5 minutes for questions. Jason said I have to speak fast. Okay, questions? Of course, Joseph, my dear friend Joseph. Yeah.
How many percent of the, the short question, can this model spread to the HPV negative or other kind of cancer except the NPC? I know.
Oh my gosh, I'll tell you. Oh, de-escalation? Okay. We actually have an ongoing HPV negative trial. where we did exactly what you said. Oh, okay, what is that? Okay, we are doing exactly the same thing, Joseph, and we're dropping to 50 gray, baby step. So what we did is we used hypoxia response, and we're going to 50 gray, because, HPV negative, we're a little bit scared. We enrolled about 6 patients out of 10, but we don't see HPV negative tumors anymore. So that's one thing. But MPC, Joseph, I don't know if you know this, I have a trial that will open where I'm going to drop my dose to 40 gray. Gross tumor, T1, T2, N1, N2. I don't do T3 because that's too daunting, that's bone involvement. I'm going to use hypoxia imaging, and we're going to drop to 40 gray. Why 40 gray? Because lymphoma, EBV lymphoma, is only 40 gray, so why go 70 gray? As right now, our subclinical dose for MPC is 40 gray only. I don't go to 50 anymore. We dropped to 40 already, meaning microscopic, but we're going to do it for gross disease to 40 gray.
Do you think there are difference between the lymph node and the primary tumor?
Thank you for asking that question. I wanted to think that way. And one of the studies, we did do that way. We actually said, all right, if your lymph node is hypoxic, but your primary is negative, 30 gray here, 70 gray here. We did that for one patient, and he failed in both sides. And then after that, we learned one thing. They might be connected. I don't know if we can be so bold that way. After him, and we're still trying to salvage him with immunotherapy. He's a young guy. But he failed both in the 70 gray and the 30 gray area, so it was really troubling for us. Yeah, I do think they're different, but I don't know if we're ready to make changes yet.
So now your policy in memorial Sloan-Kettering, both are 70 gray or both to the 30 gray, right?
Say that again?
For tumor and the lymph node, both T and N both is 70 gray, or T and N both is 30 gray?
Yes, right now that's what we do. That's why we do both of them same thing. Let's say if your primary is negative but lymph node is positive, we're going to treat everything to 70 gray, unfortunately. But I have one trial, that's one of the other trials that completed where I was fancy. I did exactly what you did, and I had that one failure. I just don't think we should do that anymore. I don't quite understand. There was some theory that the lymph node and primary, even though separate, they're actually connected, maybe biologically, so you have to be a little bit cautious that way.
That's the question, because I will get a chance to Daniel. What about the so-called CTV?
Yeah.
Do you think all your concept will change the concept of the CTV?
CTV in what sense? CTV?
There's a subclinical disease.
Yeah, we only go to 30 gray right now already.
All the subclinical.
Oh, yeah. Only 30 gray.
So you no longer believe of the so-called big tumor near the more radiation dose, but small tumor near the smaller dose? No? No,
we didn't. That was the, I know, it's very aggressive. The reason we did that, Joseph, is if we were treating a gross disease to 30 gray, it didn't make sense to treat the microscopic to 50 gray or 56 gray. So we made a decision in 2017 as a department, everything 30 gray. Didn't matter T1, T2, T3, T4, microscopic, only 30 gray.
Hello?
Yes.
Okay, great. Beautiful talk, Nancy.
Yeah.
You made a very convincing argument about, biology-directed radiation. I agree with everything you just said. Maybe to follow up on that question, I guess. So I was going to ask that exact same question about difference between primary and nodes. So now my question is, how crucial is it for that protocol to be successful that the primary stays in place? How important is it that the primary stays in place? Because, isn't TORS sort of like the standard of care, and if many places that is the how do you implement that with this protocol?
So to be honest, our recent protocol, we don't do TORS anymore. Initially, because of NIH funding issue, I had to do TORS, right? But I actually like TORS because I want to get the tissue to study. So, but it is not critical at all. Yeah. Okay, yeah. We have
I'd
one
like
more
to,
minute, yeah.
to ask whether I miscatch your concept. You mean the pre-radiation hypoxic PET, you see the change after 30 gray. If the change is great, it means you can de-escalate that. Okay.
Exactly. And in Michigan, actually, I was talking to
You cannot depend on radiotherapy.
Great question. We don't do that anymore. In the initial protocols, we had pre, and everybody had pre, and everyone had week 2. But we found that all the decision happened at week 2, so we dropped this one. Because it doesn't matter if you're positive or negative, but week 2 is the deciding point. So we just do one scan, make it very simple for patients. 11:05, is that our time? Okay, so anyway, if you have any questions, I'm happy around before I go shopping, okay? So find me. Thank you. Thank you so much.